Well, you found me. Welcome to More Smiles podcast, and we're going to be starting with our first. I'm going to call it a season and an episode. Uh, we were originally going to be talking about clear aligner therapy, such as Invisalign, but by popular demand, we're going to be talking about oral appliance therapy for sleep breathing disorders. I have decided that to follow the way that the TV industry does it. Um, we're going to call them seasons and episodes. And season one will be about sleep breathing disorders and oral appliance therapy, and there'll be four episodes. The first one today will be oral appliance therapy to treat snoring, that is obstructive sleep apnea or OSA. What is sleep breathing disorder, and what does oral appliance therapy do, and how do we know it works? The next one, season one, episode two, will be what is sleep, the stages of sleep explained, sleep test basics explained, and then who can test you and what I use to monitor the success of your treatment. Episode three will be alternatives for treating sleep breathing disorders, such as combination therapy and things you see on TV. I'll be discussing insomnia, which is the number one sleep disorder, by the way, not obstructive sleep apnea, and cognitive behavioral therapy and other ways of treating it that your physician may suggest to you. I'll be talking about sleep breathing disorders in your child, ADD, ADHD, allergies, tonsils and adenoids, and the role of orthodontics in developing your child's airway properly or messing it up. Episode four will be a wrap up. I'll go over things I feel like I needed to cover better. And also, we'll be answering questions that you can send to us at askmoresmiles@gmail.com. That's askmoresmiles@gmail.com. And I'm excited about that part especially because on social media, as I said in a previous reel, we see a lot of questions that there's no professional on the social media app to answer. So I'm excited about doing that. So let's get started with season one, episode one. So, what is a sleep breathing disorder? So, there are probably about 200 sleep disorders out there, and the one that people talk about the most is somebody snoring. And snoring is caused by in your side and on your back during certain stages of sleep, which I'll explain in another episode. Your tongue falls back, and then if it starts to vibrate as you're trying to breathe, it makes a sound of snoring like that, and that gives you hypopnea or low oxygen. Now, if it falls back and stays there for a while, you stop breathing, and your oxygen level drops down dangerously and can lead to a stroke or a heart attack. Why is it so dangerous besides scaring your spouse or bed partner or your grandchildren or the dog that normally sleeps with you out of the bedroom, or hunting camp where you aggravate everybody with you, or everybody in the firehouse who's trying to sleep while you're snoring? There are 11 different problems that obstructive sleep apnea can cause, and brain fog. You can't do well in the morning if your memory is not formed well during REM sleep or dream sleep. Anxiety because you have low oxygen and you're just anxious about things and your body hasn't really had time to develop restfulness. As I mentioned, you can have a stroke or a heart attack when your oxygen level drops down. Obesity. I'll be explaining to you why having obstructive sleep apnea can cause obesity, and also how obesity can cause obstructive sleep apnea. Impotence because of lack of blood flow. Um, as I said, congestive heart failure, depression, high blood pressure. We take blood pressure on every patient that sees our hygienist and before certain operative procedures. And we see time and time again people with obstructive sleep apnea having high blood pressure. So anytime a patient has high blood pressure, we ask them, do you have a sleep breathing disorder? Arrhythmias of the heart, obviously low blood oxygen levels, which can lead to all sorts of injuries, and type 2 diabetes. One thing of interest is that every time we see a patient with so-called TMJ or myofascial pain, or who grind their teeth and even sometimes clenches, we always rule out a sleep breathing disorder or obstructive sleep apnea. We often may get or do a referral rather to a physician who can order a sleep test for them and rule that out, because sometimes if you just treat the sleep breathing disorder, the other signs and symptoms go away. So we have a situation where your jaw falls backwards, and so what we do with oral appliance therapy, as opposed to a CPAP, instead of pushing air in, we move the jaw forward and hold it forward so that it doesn't drop backwards. Now, if any of you have taken a CPR class and learned about rescue breathing, what oral appliance therapy does is, as I said, it pulls the jaw forward. When you rescue breathe a patient, a victim rather, you tilt their head so you don't breathe into their stomach, and you pull the jaw forward. Well, there are 5 pairs of muscles that are attached to the front of the jaw, and as you pull the jaw forward, the obviously the airway opens up anterior, posteriorly, front to back, vertically, and then mostly laterally to the side, and it opens up the airway. So a CPAP pushes air into that airway and pops it open, whereas an oral appliance holds it open and allows air to come in. So how does it work? Well, in mild to moderate cases, it works just as well with cognitive repair, cardiovascular repair, and getting improvement of excessive daytime sleepiness. How do you know it's working? Well, we go by 2 things. First of all, we do subjective maximum medical improvement, or a subjective MMI. Are you no longer snoring? And if you don't have a bed partner, or sometimes if you do, we have an app for that you can actually listen to see if you're snoring. And once that snoring has been reduced to what we've used for 50 years to be a normal level, that's one achievement. But how do you feel? Do you feel better? And if you don't snore or stop breathing and you don't feel better, we will often go ahead and do a sleep test on you, very inexpensive, not like the sleep test the physician does, but either something called pulse oximetry, or we use a level 2 sleep test to just run some numbers, and then we can adjust the appliance. So these appliances that doctors like me use are adjustable. That's what the American Academy of Sleep Medicine, the physicians organization that board certifies or teaches physicians to be able to be board certified by the Internal Medicine Association in sleep medicine. It teaches them that you need to have an adjustable appliance, custom made by an FDA approved lab tech through a qualified dentist. So what is a qualified dentist? I have a diplomate status in the American Board of Dental Sleep Medicine. I'm board certified in dental sleep medicine, and I have to study a lot of what the physicians know, and they have to study what I do. So we work as a team together by a standard of practice that we use. Well, as I want to say, there's over 200 appliances out there. In some way, shape, or form, they pull the jaw forward, and there's only about really truly only 8 different designs. My most popular design that I use has posts on it that actually just hold the jaw forward and keep it there. So there's little posts that hold the jaw forward, and then you can change out these devices and different different ways, pull the jaw forward and let it go back until the airway opens up and you get the results you want. Others have little, like dorsal fins and something adjustable that you can crank to pull the jaw forward and back. I try not to use those because it kind of junks things up a little bit. One of my favorites that's been around, but it's not the one I use most of the time, um, is called a tap appliance. It has a little adjustment in the front, so it makes it easy for patients to use. One I try to avoid using at all costs is called a Herps. It has these big pistons on the side, and although it can work, patients hate it, and I don't like using it. Um, there are some really cheap devices out there that just have straps on them that hold the jaw forward, and the straps are changed. So one way, shape, or form, something is adjusted or something is changed out to pull the jaw forward or let it come back until you get maximum medical improvement and improve your airway. Now, once we get subjective maximum medical improvement, you feel better, we don't think you're snoring anymore by some determination, we send you back to the physician that referred you to us for an objective assessment of maximum medical improvement. And that would be another sleep test. Usually a level 2 is what I prefer. Sometimes they'll use a level 3. Sometimes they'll even use a polysomnogram in a hospital setting again, which may be necessary if you've had some injuries to your head. But once we know that you're doing better, then it's just maintenance. And we ask you to try to watch your weight, because sometimes when you gain weight, you need to have it adjusted again to pull the jaw more forward to compensate for the fat that is built up in your, what we call cricomental space, your neck right there. So I've had a couple of patients lose weight and it starts snoring again. But generally speaking, once you're sleeping well, you're enabled to lose weight. And we'll talk about that as one of the alternatives in a future episode. But that is a hot topic right now that can work for some people. And actually, I'll explain to you how it worked for me. So that is the very, very basics of oral appliance therapy. What obstructive sleep apnea is, what oral appliance therapy can do, and how do we know that it's working. And then it's not like a CPAP where we give it to you and then we say, good luck, have a good day. We ask you to call us the next day to tell you how you did. And then we follow you up for a while until we're sure that you're doing better. And I have a really good success rate. I'm very pleased to say that. I do have some non-responders because it's a medical trial, but I try to pick my battles very carefully, teamed with a physician, and then we have a good success rate. And you can wear this the rest of your life, or sometimes your sleep apnea will go away if you're one of those lucky people that can lose weight. I do, however, treat some very lean people, even some athletes. And there are some people that you would think, surely because they're heavy set or something, they have sleep apnea. Well, that's not true. When I worked with the New Orleans Saints, a lot of the offensive linemen who are just big guys didn't have sleep apnea. Unfortunately, some of them develop it later after football. But there were some very lean defensive backs, for instance, that did have sleep apnea. So you really can't look at somebody and say if they have sleep apnea or not. One more thing I wanted to get to, I was starting to close, but one more thing I wanted to get to was, does this cause any problems? Because people ask all the time. There are problems that can be caused and avoided, and they can be dealt with. They're very, very simple. And we explain that to every patient and show them what we're going to do to avoid it and what we can do to treat it. For instance, these devices are on somebody's teeth. And the ones I like to use are very, very firm, and they are milled out of a solid block of medical grade acrylic. So they hold onto the teeth very snugly, and it's very comfortable. But if a tooth starts to hurt, that means something in the digital image or something the lab did is not just right, and you have to come back to me to get it adjusted. For the devices that I use that have a soft reline material in them to protect maybe someone's veneers that they're worried about, and I don't always need to do that, it may cause a space to open up or a tooth to move slightly, but it's usually not that big of a deal. The ones that are the harder devices, which are my preference, actually act like orthodontic retainers, and the teeth don't tend to move or get spaces between them. Can they pull off a crown? The ones that are very snug and are milled, they can, but usually the cement is old and it's getting loose, and you just cement the crown back on. Can it chip a tooth? If you have very thin teeth, I'll caution you about that, but usually I'll make a space or I'll use a soft liner material so it doesn't damage the tooth. Sore muscles, that means something I have to adjust, like if it fits too tightly, I may have to adjust the way the two devices, the upper and lower arch, come together. Pain in the jaw joints, well, I'm pulling your jaw forward, so rarely there's something called synovitis, inflammation of the synovial capsule of your temporomandibular joint or your TMJ. The literature shows that it goes away in 6 to 8 weeks, but I always like to know about it. and that way I might move your mandible back a little while and move it more forward. So you move these devices forward and back to open up the airway more when it's needed. So the last and final possible complication is something called posterior open bite, where because you had to jaw forward for 5, 6, 7 hours, a little muscle that actually opens the jaw up here in front of your ears may get shortened, just like you're sitting at a desk typing and you get up and your lower back muscles are tight, or some fluid may build up in the synovial capsules of your temporomandibular joint. And sometimes people will sense that it feels like their bite stays forward. So we avoid that from happening long term by this. You get up in the morning, you take the device. Here's my favorite one right here, the milled, and you take it apart and you rinse it off, hide it from your dog and your cat because they love to eat these things, and then you put another device in your mouth called the morning occlusal guide, which is an index of how your original bite was. And then you go about your morning routine. After about 5 and 15 minutes, you take it out. The bite feels good, rinse it off. Now, it doesn't happen to everybody. A lot of people say, didn't need that. My bite feels good. But I insist that everybody use it at least for the first year. Um, some people feel like they need to keep using it. Most of my patients tell me that they quit using it at some point. And I just tell them they're on their own, but I look and their back teeth are touching just like they always did. We actually take a digital record of how the bite is so we can see if it did happen or not. So that's how it works. Um, when we make these devices, after we do the exam and look at the any radiographs we need to check things out, we do take a digital image, not a GUI impression. We take it digitally and we record the original bite and then where we want to start your jaw, moving it forward. And then so we can tell what's been going on, if anything harmful has happened. But it rarely, rarely does, especially if a patient is compliant with using the morning occlusal guard. So that is pretty much the basics of oral appliance therapy to treat sleep breathing disorders. Sorry, I got a little bit out of order there, but I think you understand now, and we're more than happy to answer any more questions at askmoresmiles@gmail.com. That's askmoresmiles@gmail.com. I hope you enjoyed this, and I hope you look forward to episode 2 of season 1. We'll be talking more detail about what is sleep and the stages of sleep and some other treatments for it. Thank you very much. Have a good night's sleep.